So good morning, my name's Trevor Kilpatrick from the Royal Melbourne Hospital, and it's my pleasure to introduce this morning Professor Amit Bar-Or, who's an international authority on multiple sclerosis. So welcome, Amit.
Thank you, Trevor, for the gracious introduction. I'm hailing from the University of Pennsylvania, where I serve as a neurologist in the MS program and run that aspect of the program, as well as direct a center that we call the Center for Neuroinflammation and Experimental Therapeutics that's very interested in better understanding why people get MS when they do, why some have more active MS than others, and what might we be able to do about it from a treatment perspective.
Thank you, Amit. So as a segue, what would you say is the most exciting thing coming out of your lab at the moment and its potential implications for benefiting people with MS in the long term?
I think one of the areas that has caught our attention is recognizing that people are different. And so there are people, as we've known for a long time, who have more active or more aggressive MS, others who have less active or aggressive MS. And as we have more and more treatments available, such that almost every day one is discussing with people whether the treatment that they're on is the one to continue or to change and what to start with when you start, what might we be able to measure that will help us understand how people differ from a biological perspective and what treatments may be better suited for one individual or another. And that becomes particularly important as you're thinking of switching and sequencing treatments over time. The concept that one treatment may leave an imprint on the immune system that may have consequences to the other treatment that you would choose subsequently. And we would like to be able to develop measurements that can be applied easily to individuals with MS, typically to the blood that we get into the lab, to better understand and predict which would be the best choice for them.
That's really interesting, and let's take a step back and just think about what are the factors which actually produce those differences. It could be bad luck, it could be factors within the person, or it could be differences in terms of exposures. Where do you see the emphasis being in terms of productivity and understanding what actually generates these differences?
So I think we've come to appreciate that MS develops in individuals based on a combination of risk factors that are represented by some genetic predisposition, although MS is not a genetic condition as such, where if one has it, then a child is likely to have it 50% of the time. It's much, much less common. The risk in a first-degree relative will be of the order of 3%, so still 97% chance not getting it. And we've learned that there are multiple different genes, none of which are abnormal per se, but in combination can increase the risk from a genetic standpoint, and then there must be some environmental exposures that are superimposed on that susceptibility to result in people developing MS. And I think the challenge biologically is that the combination of genetic and environmental factors need not be identical across individuals, and that these interactions between the genes and the environment ultimately have an impact on cells of the immune system that we think participate in MS, resulting in perhaps different combinations of cells that contribute to the development and the activity of MS that differ across individuals. And that is to the earlier point of trying to understand how we may be able to measure that and then tailor the treatment. So it goes very much to the point you're raising about what different combinations may lead to the development of what we call the same condition, but with some, one would call it heterogeneity across individuals.
So that's once again really interesting. Are you implying there it's not just like a rheostat whereby it's low, medium or high, but there are actually different pathways which actually might lead to a common enunciation clinically of what we as clinicians describe as multiple sclerosis?
That's exactly right. And I think that ultimately what we call a condition it ought to be guided by what is the best treatment that results in stopping injury, helping repair. And if it's different across individuals, we need to understand that. And if we wish to call people under the same umbrella of a diagnosis, but recognizing that they may be biologically different in a way that warrants different treatments, that's an important point to capture. We had thought for years that the bad guy cells of the immune system in MS are amongst the T cells of the immune system. T cells are known to be orchestrators of other immune cell responses that help us normally protect ourselves, for instance, from infection and cancer. And if they're not properly regulated, the T cells may do bad things, including injury to ourselves. And when it's to the central nervous system, this was thought to be a major component of MS. And the evolution of the thinking, partly work in our group, but work by many others as well, has come to appreciate that it's not just about T cells, it's about different types of cells. And again, the names of the particular cells are not as important as recognizing that T cells and B cells and other cells each can contribute, and they interact with one another. It's the consequence of their interactions and the balances and checks between them that will define whether the immune system response sort of spills over into causing MS or new MS activity. And the point being that different combinations of these interactions may spill over. So once spilling over, you have a condition that we've called MS, but it may be that there are different reasons for the spillover in different individuals that we ought to understand to guide the treatment.
Okay, so thinking about a perspective from a patient's viewpoint, what do you think about the hope of actually identifying these differences a priori before therapy is started, as opposed to monitoring the benefits or lack of response to therapy? Do you think that there is hope in the near future of being able to predict, as opposed to having to say, look, we put this person on this therapy, they haven't responded well, so therefore we need to empirically try something else? Right. Where are we in terms of that?
Well, I think we are early in the process of trying to understand what we can measure early on prior to treatment to predict the outcome. Once we've recognized that there is this heterogeneity, what we need to do is we need to collect information that will inform us on what may be predictive or not. So what we need to do is we need to either make the correct measurements or at least collect the samples that will enable us to make the correct measurements and store them, and then follow people over time. Some people will prove that they responded well to a treatment, others not. We would like to go back to those original pre-treatment samples and understand if there's anything that may have distinguished them. That is part of what we call development of the biological marker, also known as biomarker. And to develop a biomarker, it takes rather a long time because you need to assess how that biomarker performs as a predictive marker. And if you don't have the longer term perspective of the outcome, you can't be sure that it's predicting the aspect of interest. So measuring early on or collecting samples that will allow you to go back to and then measure is what will reveal the biological differences early on that may predict the outcome. So, and in fact, the most compelling context to try to do this is in the context of the very well-organized clinical trials of therapies, where people are exposed either to the treatment or to the control, and they're randomized, meaning that there's a balance between the different arms of the study, and people are followed very carefully with research quality, clinical assessments, and brain MRIs, for example. So you know how people do, and if you collected the right samples in that context, you'd be able to go and ask those questions much more productively. If you try to do this in the clinic, it's still a worthwhile endeavor, but you may have to work harder to get people monitored as closely and as consistently as someone is investing in the context of a clinical trial.
And to interpret what you're saying, really, in effect, it's not just about cross-sectional correlation, it's actually about prospective analysis and then being able to correlate with the outcome, which is absolutely crucial here.
Exactly. It's the context of following people carefully and consistently over time from a clinical standpoint, from the imaging standpoint, and the biological assessment standpoint.
Okay, and I guess in MS there's complexity here because you've talked about the heterogeneity, but also there are phases where the disease is active and inactive, and there are also compartments as well. And one could see in certain circumstances where cells which are responsible for pathology in the periphery might be hidden elsewhere, still there, but you can be tricked just assessing the peripheral blood to think,
Correct.
Well, actually things have improved in terms of pathogenic stimuli, so to speak, but actually they're still harbored within the body somewhere.
Absolutely.
And how do you tease that out?
Well, it's a challenge because we have access to certain compartments more readily than others, but that's not necessarily where the business end of the immune system is in terms of MS. And so if you think of the normal state, we have immune organs, lymph nodes, spleen, and so on, that are deeper inside our bodies, that are involved in cells getting activated when appropriate. and they then course through the blood on their way to wherever they need to get to, for instance, to survey the tissue from an infection. That's the normal state. The blood is an important compartment of transition, if you like, but it's not where the action actually takes place. Yet it is the compartment that we have access to more readily because we are not able to biopsy lymph nodes or, for that matter, the brain on a regular basis. So while we do know that the important immune activation is occurring either in the lymph nodes or in the target organ itself, the central nervous system in MS, and yet don't have access to those compartments, the question is, can we interrogate immune cells in the blood in a way that may inform us about that? And most of the immune cells that are transitioning are actually pretty quiescent, meaning they're not activated and not necessarily that informative until you ask them to do something. And if you get them and they're healthy enough and you can activate them, you may bring out some of the abnormalities that may play out within the target organ, the CNS or the lymph nodes. So we've learned to try, when we can, to correlate spinal fluid cells and blood cells. And when we figure out what connections can be made, we'll then turn to the more accessible blood and try to use that as a proxy biomarker as opposed to the target organ. And overcoming this challenge of having more access to samples that are not the actual target organ is something that we need to work on iteratively over time and keep getting additional clues and hints and figure out what it is that we can meaningfully measure.
Thank you. So it's a perfect segue to another deep question which I sometimes contemplate, and that is a comparison and contrast with our successes versus the successes in the rheumatoid arthritis field. Mm-hmm. If we talk to our rheumatoid arthritis colleagues, basically they say, we don't see erosive arthritis now. Basically, immunotherapy has completely transformed the management of rheumatoid arthritis. We can reflect upon great successes in multiple sclerosis, but I don't think we can actually put our hands on our heart and say we have completely averted the prospect of progressive multiple sclerosis at this point of time.
Yes.
Now, do you view this as a compartment issue? Obviously, one can think about synovial tissue relatively accessible, and so therefore it might be an easier ask for immunotherapy to be effective. Or do you think that there's something fundamentally different or something additional which is relevant to our relative lack of success compared to the rheumatologist?
It's an excellent question, Trevor. I think that our success, which is no lesser than in the rheumatoid arthritis field, is our ability to do a better and better job at really limiting the relapsing aspects of multiple sclerosis. And those, we think, reflect immune cells outside of the central nervous system that get inappropriately activated and traffic to the CNS, the central nervous system, where they participate in the relapsing damage. And by preventing that process, we have substantially limited relapses. As you point out, though, we have not had nearly as big a dent on progressive aspects of MS. And I think you're right that this is, at least in part, related to different compartments, where the non-relapsing aspect of MS, the progressive aspect of MS, is likely to reflect an injury process that is happening within the central nervous system and may have a life of its own, at least at some point. It may have been triggered by these waves of relapsing attacks, but at least at some point, and maybe even from early on, is present within the CNS, likely involves some aspect of immune system responses interacting with the brain cells, and that interaction may lead to these sort of positive cascades or positive feedback loops, as we call them, and a chronic cascade of a different injury mechanism that is not nearly as successfully targeted by those therapies that we apply outside of the central nervous system that can be very good at limiting relapses. So what we need to do with therapies that will effectively target progressive MS is have therapies that will access the central nervous system, either by getting in there themselves and having an effect there, or doing something in the periphery that translates into a change in the central nervous system. And there may be ways to do that with the immune system, and some of the most exciting new approaches that are still immune therapies are trying to take advantage of the very clever immune system's normal capacity to go places and do things at the right time in the right place. And if we could harness that to deliver into the central nervous system some kind of molecules that may acquiesce the injury process, perhaps reverse it, and perhaps even promote repair. That, I think, is a horizon of treatments designed to both stop the progressive MS biology and perhaps, in fact, contribute to repair mechanisms, which, of course, another major unmet need in MS.
Of course, this has been an old chestnut, hasn't it, in the MS field, the association or otherwise between immunopathology and neurodegeneration.
Absolutely.
And there's been some recent data from the Karolinska looking at MHC presentation by oligodendrocytes.
Yes.
And I'm just wondering the extent to which this is providing some insights into previously unanswered questions in terms of this connectivity, and what you believe is the implication of that particular genre of research which is getting some airplay at the moment.
Yes, I think that's correct. So to your point, the MHC, of course, represents the family of molecules which define us as individuals immunologically. Those are the ones that we try to match in the context of transplantation. And those molecules are very relevant to triggering normal T-cell responses. Without those molecules, you will not have T-cells respond. You need those molecules for their normal response, but their presence, perhaps by the wrong cells at the wrong time, may invoke responses of T cells that can contribute to local damage. And as you point out, over the years it's been difficult for us to make firm connections between the measurements in the immune system that we can capture in the periphery and how they may translate into progressive MS within the central nervous system. This observation by our colleagues at the Karolinska that there may be now a better understanding at a molecular level of how cells of the immune system interact with target cells of the brain, including the myelin-making oligodendrocytes, may be one of those missing links that can help us reconcile and makes the point, I think, that whereas we have sometimes referred to relapses as being immune-related, inflammatory, and progressive disease being degenerative, that there may nonetheless be an important immune or inflammatory component to what we've considered degenerative. Now, that doesn't preclude degenerative mechanisms as elegantly described by colleagues in the field, but what it does remind us is that if we called something strictly speaking degenerative, we stop thinking about the potential for immune-directed therapies to benefit that process. And so I think the takeaway message is that inflammation or an immune response of some flavor, of some type, is almost certainly relevant both in the periphery with respect to relapsing biology, but also within the CNS with respect to progressive biology. And that inflammation and how it impacts degenerative mechanisms provides opportunities for treatment or therapeutic targeting of either the inflammatory contributor or the degeneration or a combination of the two.
Thank you. And just to end, Amit, I'd like to ask you a very practical question. Obviously, we've been talking a lot about mechanisms, a lot about hope for the future, connectivity between the immune system and the brain. But at the level of patient management, as of 2019, given the heterogeneity that you describe, and the challenge of recognizing that heterogeneity up front, how do you personally manage people with multiple sclerosis at that early stage? Are you an advocate of escalation of therapy, or you're an advocate of induction? How do you approach the management of your patients in broad terms?
So I certainly think that it is not a one-size-fits-all. I think that while I tend to want to stop any new injury, which would have me gravitate more towards using stronger treatments earlier on, I don't necessarily think that that is the correct approach for all individuals, and I think that there are people who, of course, will have more concern about the effect of the treatment than the effect of the MS, and a lot of this is about education as well. But at the end of the day, there are people we know who have MS who can manage without really sustaining much damage with relatively mild therapies, and others who absolutely need stronger therapies, otherwise they will end up with damage that is irreversible and builds up rapidly. We are not yet at the stage where we are good at predicting who is who at an individual level. We can talk about averages, that on the average, if you have these features, you may have more aggressive MS, but we still haven't really brought it down to the level of the individual. So I think also that an important point that I try to make as I'm discussing treatment options with people with new diagnoses is that as we think of the increasing number of options we have, and people feel like this today is the most important decision I will ever make in my life, it is an important decision, but to put it into perspective, what you decide may make sense today based on the information you have, should not be viewed as a marriage for life. You start something today that you've discussed with your caregiving team based on features of the medication, what you think will be the benefit, what may be the risks in an individual, that makes most sense at that time, and you go on the treatment and then you're followed closely. And you're followed closely both to understand whether you tolerate the treatment well or have any adverse effects that might require you to change, but you also follow people even on a therapy to try to detect any evidence of new MS activity. I refer to that as proactive follow-up, and that allows us to capture much earlier than we would have in the past the development of new MS activity while on a treatment that would suggest that this treatment is not quite as strong for your MS. And then you're in a position to make a decision about escalating. So I tend to be more, let's try something stronger up front to really acquiesce MS, but I'm perfectly comfortable with something that is not as strong because I know that the person will be followed closely and will be able to react more quickly and, if needed, escalate the treatment.
Thank you very much, Amit.
Pleasure. Thanks.
Great.
Thanks, Greg.